Welcome, friends. Today we have Shannon Weise with us. He's a licensed clinical social worker who works with people dealing with obsessive compulsive disorder. Welcome, Shannon.
Thank you.
We'll go over what OCD is, what are the treatment options, or what do we do. Also, for people who are providing care or who have relative with OCD, how can we understand and compassionately help treatment or care for a person?
Okay. Maybe we would start with what is OCD. So generally, at least for me, I'm getting people who are coming to me with a pretty clear indication that they have OCD and they've been living with it for some time. But to be diagnosed with OCD, usually they have to have both compulsions and obsessions. That is something that has recently changed in diagnostic criteria. It could be either obsessions or compulsions. But what we've seen is that usually, even if people say, oh, I have these obsessive thoughts and I only have obsessions, they also have compulsions that go along with it. They may be mental in nature.
Mm-hmm.
And these obsessions and compulsions have to affect their daily life in some way. So academically, work-wise, anything like that.
They know the thought is not, they don't want to have that thought. People use commonly example of checking lock or cleanliness obsession, and then they have to wash their hands as a compulsion.
Yes. OCD is ego dystonic, where they people actually know, like, I don't want to be having this thought doesn't make sense to me, doesn't seem right. An example of a difference of that would be someone with an eating disorder who actually believes that the thoughts make sense to them, and that is what they want to be doing. So that would be ego symptom.
So also sometimes kids might not differentiate whether they don't want to have that thought. They would just follow the compulsion. Sometimes obsessions could be about things like religion or family member and thoughts that might be considered sin. Does that come into play for your clients?
Yeah, so I'd love to talk about that, because I think the idea of OCD for most people is people washing their hands compulsively, or organizing or checking door locks, and I think that's what people think of when they think of OCD. And actually, I would say the majority of my caseload is other types of OCD. So I would love to provide education on some of those other types. So there's all sorts of other names that people come up with, but there's something called harm OCD, pedophile OCD. There are all sorts of terms people kind of have floating around out there, hit and run OCD. What used to just be called sexual obsessions, now some people refer to parts of that as pedophile OCD. So some folks have intrusive thoughts about sexually harming children and are really, really distraught by these thoughts. So I see a lot of people coming to me with that kind of content.
Mm-hmm.
So that's one of the ones that doesn't get talked about a lot.
Right. Because of the associated guilt or the label that it might bring, the person might start questioning their core self or values or identity.
Absolutely. And there's a lot of sometimes there's a lot of work that has to happen, getting someone to accept that this actually is OCD. These thoughts aren't true, before they're willing to do the work, and just educating and all of those things.
Mm-hmm.
So there's also harm OCD, where people might have a thought that they're chopping vegetables and they're like, what if I stabbed my husband? Driving down the road, thinking that they hit someone with their car, different things like that.
When I was learning about OCD in residency, my teacher Dr. Sudak. She had us write the name of the person you love the most on the piece of paper, and then she's after we finished, she said, write in front of that something like, "Will die today in an accident," and we were like, "No, we can't do that." And she was like, "That's the magical thinking that you thought if you would write, that might happen." And that's how people with OCD live in these fears or some of those thoughts that might happen all the time.
Yes, that's a great example. Yeah, and that's also a great example of exposure.
One other thing, people who are religious, and usually it attaches on to things people care about. So if somebody's religious, usually the obsessions could attach about some negative thoughts about God or some of those absurd thoughts that they want to stop it, but they can't, and they think they're sinning every time they're having that thought.
Yes. Yes, so scrupulosity, religious OCD is referred to as scrupulosity. There's also moral scrupulosity, so many subtypes of OCD or different themes.
Got it. Okay. If somebody has OCD and you are meeting with the client, how do you explain to them what would be the treatment option? Probably everybody wants to get help or treatment, but some of the treatment, particularly in this case, I think we are saying is not easy.
It's not easy, no. So I think what I see is a lot of people have spent years talking about their OCD, which does not help it. And really, like, the gold standard treatment is something called exposure and response prevention. And of course, medication is helpful as well for some people. So what exposure and response prevention is a type of cognitive behavioral therapy in which we expose ourselves to whatever it is we fear. So it could be a thought, it could be a thing, an experience, without doing, and then the response prevention part of that is not doing the thing that makes you feel better. So if it's checking the locks repeatedly or something like that, it's resisting that urge to do those things.
Mm-hmm. So what would exposure look like?
Depending what the core fear is, so we really do a lot of work. So setting up exposure and response prevention for a client. So I have my little whiteboard here. I was going to maybe do a little drawing for you. So I usually present it to my clients like the first session like this. I do this little drawing to try to, and I'm not a good drawer here, but I do this little drawing. You can see it. This is the obsessive thought. This is to try to get them to buy into doing exposure and response prevention. Mm-hmm. So this is the obsession here. And then this is the compulsion. So we have an obsession, we do something to feel better, and we feel better for a little bit, but then a thought pops back up, right? So what we do with exposure and response prevention is we stop doing all of this, which is the response prevention, and instead we stay up here and we try to be anxious. We try to be uncomfortable with whatever it is. Mm-hmm. And then usually this thing happens after some time, and it's called habituation. And it sort of looks, I'm like so bad at drawing, but it looks like this. And so what that means is your distress level comes down, or you get used to the anxiety, you get okay with it. So even if habituation doesn't occur where the anxiety actually goes away, mm-hmm. something happens where we change the relationship with the anxiety. So anyway, this is kind of what I start off with in talking to people.
That is so helpful. And mm-hmm. so in a way, we are facing our fears. And then when we are getting the thought to act on that fear, we are resisting urge to do that. And and then as we keep doing it, over time, obsession loses its power.
Yes. And so one of the things that we do in starting treatment is we come up with, I know you're asking about the door lock, so I can kind of give you an idea. So what we do, we have a couple of sessions, we assess where the OCD is, like how severe and all of that. And then we also, we come up with a menu or a list or a hierarchy. Some people aren't using hierarchies as much anymore, so we call them menus or something. But we make a list basically of all the things that the person fears, whatever it is that they obsess over, and then all the things that they do to feel better. And then we start kind of tackling each one of those. So if it is that I check the door 4 times before bed or something because I'm afraid of harm coming to my family, if that's the core fear or the worry, then we work on all sorts of exposures addressing that fear. So it's not just about, well, we stop checking the door. We actually go towards that fear. So, and we get creative. I get super creative coming up with all sorts of ways to have exposure to that.
So in hierarchy, it seems like you start with the thing they can do, and then it's like video game. You up the level till it creates distress, then you stay on that, then move forward.
Yes. Now, more research is showing that jumping around the hierarchy is better, or starting with harder sooner is better. So I just kind of say, well, you can tell me either how willing you are to do something and how hard would it be, and then we just pick different things randomly off of the list. So we don't just go with the easiest. Now, if it's somebody who's really resistant to doing the work, then of course we start with the easiest. Try to help people do them, do them with them, that kind of thing.
Because of this obsessional thinking, I think people who are taking care of a person with OCD, even relatives, family members, or even providers, they could get really annoyed at times because the same question or same thing would have to be repeated. How can they handle it better?
Sure. So, with treatment, at least with treatment with me, I spend a lot of time bringing family or spouses in and educating them about the disorder, about what they can be doing to help and support their partner or their family member, ways in which they should stop accommodating the OCD, which is usually the case. I've probably never met anyone who's never had someone reassuring them or doing things for them to make them feel better. So there's a lot of time spent undoing some of that stuff. Probably one of the first things that we work on in treatment for the individual and then for the families is working on not reassuring. So that's number one. It's usually first session, and then a couple weeks they're just working on that. So that just really educating the family, encouraging them as well, teaching them what to say instead of providing reassurance, because I think it's pretty natural as a parent or even a spouse to want to make your partner feel better. So just letting them know that they can offer comfort in other ways without reassuring about the fear.
Got it.
There is a great book called When a Family Member Has OCD by John Hirschfield. It's actually really good. I recommend that sometimes.
Awesome. So if somebody's saying, I'm afraid to go to school, shooting might happen. So instead of reassuring, you're saying we are still doing it?
We're still doing it anyway. So, with a child, we use a lot of reward systems, a lot of cotton ball jars and things like that to help encourage. So there might be some incentive in that saying, hey, well, you'll get a cotton ball if you go to school today without any issue. But usually what is being said is, you know what, I can't reassure you that nothing is going to happen at school today, but if you go and you try, I can offer a hug when you get home today, or, something like that. Or I can sit here with you for a few minutes while you're uncomfortable. But then we're going to move forward and go.
Awesome. That's a great introduction to the model. Anything important that you feel in this introduction that, of course, for the viewers, if you have questions, write down in the comments. We'll ask Shannon and answer your queries. But Shannon, is there anything else?
So it's pretty fun for me to do the work because I also get to see people get better and pretty quickly. That there is help out there, making sure that you are getting the right help if that, if you do think that you have OCD and that talk therapy doesn't work for this disorder. And reassurance doesn't work. It works for a short time. So really stopping that. Do the hard stuff. That's the other thing. Yeah. So I think that's a good motto anyway, just in how to live life.
Awesome. I'm really thankful to you, Shannon, for this hope and introduction to the exposure model. And when anybody tries it, it might not feel easy, but keep trying. Shannon works closely with her clients. You see in your area, if you have somebody, try with them. Otherwise, find resources online nowadays.
Right. The International OCD Foundation is a great resource. There's tons of stuff on there. They're always offering live sessions, support.
Awesome. And I will put that link in the description below as well. And one closing remark also, I would say, as you are dealing with this, have a lot of self-compassion. Don't be too hard on yourself. And rather than looking at perfection, look at good enough and then be okay with that. So thank you so much.
Yes, thank you.